and today I'll be talking on giant cell tumor of bone and what are the clinical considerations. Like any orthopedic surgeon or any radiologist, any oncologist will be aware of giant cell tumor, the general aspects of it. But what does a clinician, if you see a patient with giant cell tumor in your clinic or when they come to you, what are the things which will influence you and what are the things which are need to get a good outcome and to be addressed during management? And I'm a clinical fellow in the musculoskeletal oncology unit at the University of Oxford at the Nuffield Orthopaedic Center at present. As you know, giant cell tumor, the incidence, there are so many different incidences, but this is the one which has been quoted in the WHO. This is 1.7 per 1 million population. So how do you, let us take it in different perspective. In the city of Mumbai, for example, they have an 18 million population. What this number quotes is there are about 35 to 40 cases which happen every year. Or if we take the city of London, for example, which has a population of about 8.9 million, it's around 25 cases which come there. This does not include the referred cases. So basically what it is in the large spectrum of sarcoma, the incidence of bone tumors are 1%. So it is really, really rare. Bone tumors and sarcoma are rare. And in that 1%, giant cell tumors have they have a 1.7% incidence in 1 million population. And in primary tumors, there is about 20%. So out of the bone tumors happening, there is 21% are giant cell tumors. And as we know regarding the incidence, now regarding the occurrence and the usual age for it is the third decade, the end of the second decade and the third decade. So 20 to age 40 is the highest preponderance, nearly 86%. And the characteristic appearance as seen in this X-ray of the distal radius is this epiphyseal metaphyseal region or having a soap bubble expansile lesion. That's how the postgraduates, the examiners like. Epiphyseal metaphyseal region with an expansile region. And there is a few studies which show that there is a female preponderance of 53.4%, which is minimal. So with this basic thing, which everyone knows of it having 20% incidence in bone tumors, high incidence in the third decade, and with its location, we'll go into the next slide. And so, for example, when we come across a lesion suspected to be a giant cell lesion, an osteolytic lesion in the metaphyseal epiphyseal region, in this case is proximal tibia and a distal femur, how do we go about it? Like usually 75% of the giant cell tumors, they occur in this region. The highest incidence is the distal femur followed by the proximal tibia. And then we have, it can even occur in the phalanges of the bones, but there is a 10% incidence in spine and in the sacrum, areas which are very difficult to manage, and that will also be covered in this talk. So how do you diagnose a giant cell tumor? So when a patient comes, usually this was actually an epidemiological study done in Norway, where they found out that 73% of bone tumors, especially, they come to a surgeon only by reference. So the general practitioner has seen it and then they order an X-ray. So getting a giant cell tumor directly referred or directly coming and seeing you for the first time is quite rare with today's modern healthcare systems. So how do you diagnose giant cell tumor? The most important symptom of any cancer, having non-mechanical pain, especially night pain, that will be the preceding symptom. And once, the first important thing is to take a radiograph, a complete anteroposterior and a lateral X-ray. So you need a two-dimensional radiograph of the affected limb. And once the radiograph, you can take CT scan and an MRI. So with this, you can do the local staging and diagnosis radiologically of a giant cell tumor. So many people ask, are there any blood tests for giant cell tumor? The only blood test which we should think is a serum parathyroid hormone, just to rule out a Brown's tumor. Like Brown's tumor, it will have diffuse osteolytic lesions. And if you are concerned about that, you need to do parathyroid hormone. Otherwise, there is nothing else you need to do. There are a few markers which are being introduced by histopathologists in industry specific for variants of giant cell tumor. That is quite extended. But the gold standard for a giant cell tumor is whatever radiologically you think you have to do a biopsy. Biopsy and histopathological diagnosis is the gold standard. As they say, if tumor is the rumor, tissue is an issue. There are a few tumors like chondroid series tumors like chondrosarcoma and chondroma where you do not need biopsy, just radiology is enough. But in giant cell tumor, because of the variance there, you need to rule out all the, you don't miss out anything. So definitely a biopsy is the gold standard for diagnosis. So then once we come to biopsy, what type of biopsy? A fluoroscopic guided needle biopsy with a J needle, it can be done, and a J needle biopsy where you get at least 4 to 5 cores. But as we know, the basic principles, the 6 basic principles of doing biopsy in tumors, I'm not going to go back on that. So with these 6 principles, for example, in a 35-year-old male, if we have this X-ray presentation of expansile lytic lesion and you suspect a giant cell tumor, you can either go, as they say, medially or laterally. But the most important thing in this case is you have to plan your biopsy, seeing the lesion and what is going to be your surgery. So the plan of surgery has to be taken into account. And for example, in this case, it's also a pathological fracture. You will need to do an extended curettage. The medial column, the weight-bearing column, it needs to be supported. So you will need to do a medial plating. So in this case, you will need to go on having a medial biopsy. You need to go in through the medial compartment. So the entire biopsy planning has to be done with your further surgery in mind, because giant cell tumor is a benign spectrum with an aggressive lesion. So you need to plan your biopsy based on the further surgical plan. And as I said, the final surgery plan. So in this case, we planned finally for a medial plating with allografts after extended curettage. So we went in medial, and so a medial biopsy was done here. The next important thing, how do you stage these? And the very well-known and renowned Campanacci staging. And you know, a grade 1 is a cystic lesion with expansile cortices with intact cortices. And these lesions are in the early stages, but are visualized better in the MRI. Stage 2, it's an expansile lesion, but the cortex is still thin. At stage 3, these are the ones which at most times patients come directly with you. They have a destructive radiolucent lesion and break in cortex, and there is a soft tissue extension. So grade 2 and grade 3 are the ones the patient will present to you with pain. Grade 1, usually they don't have pain. It is sometimes even an incidental diagnosis. As you know, Campanacci's radiological grading, but you know, this was laid out long time before, but nowadays with modern imaging and with modern techniques, we also have the Enneking staging of a benign GCT, which is collaborative with the Campanacci's grading, like stage 1 is collaborative with grade 1. So grade 3 is the one which is about 10-15%, which has the rapidly growing cortex perforated. So a stage 3 Enneking is almost reminiscent of a stage 3 Capana. So once you do the biopsy, this is an example of a histopathological slide where you see the numerous giant cells which are seen there. And the Jaffe staging system is one more system where they have 3 different grades, where the number of cells and the cellular atypia is seen into consideration. So it is also important for you to discuss with your oncopathologist and also for the pathologist to be experienced in this, where they can pick up the stage and also see the cellular atypia. And as you know, giant cells are not neoplastic. They are primitive non-stromal cells. They affect the rank ligand pathway. And depending on the cellular atypia pathology, because this directly has an influence on the recurrence of the tumor. So you also have to be very aware of the mimicking lesions, and chondroblastoma and even multiple fluid lives cavity, a secondary ABC could be mimicking a giant cell tumor, and also a multiple myeloma can mimic giant cell tumor. In the next talk, Dr. Pushpa will talk in detail about the radiology, so I'm not going into that. But if these lesions, if you mistake it also, principle of management almost the same. Multiple myeloma, good drug therapy. But the one thing you have to be worried about is telangiectatic osteosarcoma, which is a high-grade variety of an osteosarcoma, less than 4% of incidence. And in this X-ray, which is a proximal tibia lesion, this turned out to be a telangiectatic osteosarcoma. So it is more important for you to be aware of this, and also for your radiologist and also for your pathologist to be aware and then take a decision. So this was a 17-year-old girl who had pain and swelling for the past 2 months, and this is expansile. If you see the X-ray, an expansile lytic lesion, looks like a Campanacci type 3 on, and many of them would think it as a GCT, which is what it looks like. But if you take the MRI scan, if you see apart from the fluid-filled cavity, there is a specific region of doubt to the clinician. And so when you are doing a biopsy through the lateral approach, you have to target this biopsy under fluoroscopic guidance. So nowadays in centers, even when radiologist takes biopsy, you have to take this lesion particularly, or else if you take the other samples, you may get a false result and you may miss the diagnosis, because the treatments for malignant ones are completely different. The next important thing is staging of a GCT. Once you confirmed it as a GCT, local staging, radiographs and two-dimensional radiographs and MRI scan is enough. So CT scans, the role is actually exactly just to find out the cortical thickness exactly. So if you have a pathological fracture, sometimes it may help, but the first two, the radiology, X-rays and the radiographs are enough. For systemic staging, there's been numerous papers that they discussed for the whole body. They used to take PET scans, bone scans, but nowadays it's been proved that if you have a single chest X-ray before surgery, that is enough. And a chest X-ray is ideal for the systemic staging of a GCT prior to surgery. And management of GCT has always been surgery. You need to do an intralesional surgery. As we know, the 4 types of surgery: marginal, intralesional, wide excision. So you just need to do an intralesional surgery. And an extended curettage has been shown to be the gold standard, where you have to do complete curettage with a high-speed burr. And that today, in today's world, there is also the medical legal part, where if you get a recurrence, there is always a question whether the high-speed burr was used. So because it gives adequate thermocoagulation and also helps in good disease clearance, so of 60,000 RPM, and adjuvants, whether phenol or hydrogen peroxide, chlorhexidine, there has been so many discussion on it, many people for it and many people against it, but there is no doubt on the use of an high-speed burr and sandwich technique with cement. So the gold standard of management is surgery. And of course, Sunil will be talking on unresectable GCTs, where of sacrum, pelvis, and spine. And with the wonder drug denosumab in 2012, which changed treatment, whether it's really effective. And also in these unresectable GCTs, prior to denosumab, they were doing a lot of interventional embolization, which is even done in many centers today. So the next question which a clinician is very much concerned is, do GCTs have a risk of metastasis? So like malignant tumors, and even if you have a patient, the patient is going to ask you, what is the rate of metastasis I have? So I'll tell this with an example. So this was a 17-year-old girl who had an expansile swelling in the phalanges of her middle finger. So in the proximal phalanx base, if you see, there is a lytic lesion. They did a biopsy. It was suggestive of GCT. And then after 3 doses of neoadjuvant therapy of injection denosumab, you could see there is a cortical shell formation happening. Then a curettage was done, and then after the wide excision, and also the autograft was used, and from the metatarsal head, and then they also used a side plate to fix it. The patient had a good outcome, and the patient was discharged, and then the patient was lost to follow-up for a long time. The patient came back after 2 years. She didn't have much symptoms of her finger, but she came with a cough during that time. And if you see her X-ray, there is diffuse metastasis seen in her case. And this is also the MRI, a CT scan, sorry, of her chest. So you have to be wary of this fact that there is a 3 to 5% chance of metastases of this GCT. And it usually occurs at 2 years, and lung is the most common site. But this was a case which was done in one of India's premier center in the Tata Memorial Hospital, where they studied metastatic giant cell tumor of the bone. And they found that even though they had metastasis, the outcome was much favorable than a malignant giant cell tumor, than a malignant disease or like an osteosarcoma metastasis or Ewing sarcoma metastasis, or the survival was much better. And they suggested that in cases where it was possible, you could do a metastatectomy, you could do a lobectomy of the lung also. Patients did well. So it is very important for clinicians to be aware that GCT of bone can metastasize. There is also a 1 to 2% variant of a GCT, which can be a metastatic GCT. The next question, what is the risk of recurrence in cases of extended curettage after surgery? This was a 34-year-old lady with a biopsy-proven GCT. If you see, it's a Campanacci type 3 with cortical thinning, cortical breakage. And after neoadjuvant denosumab, there was a good shell cover. And type 3 GCT with soft tissue extension, especially the lateral. If you focus on the lateral image, there is a soft tissue extension here. And in this region, it's always very difficult for you to attain curettage. So extended curettage was done, and they had 5-6 burrings at the entire femur, distal femur. And after cement application, the patient did well, but 6 months later, the patient had pain. So in such a situation, how do we detect early recurrence? If you do a CT scan or an MRI, MRIs, even if you do a image subtraction or a metal subtraction MRI, there is going to be a lot of image scatter. In such cases, you can do a PET scan. And if you see within 6 months, the PET scan has the red color indicates a high uptake of the inflammation activity, and that suggested recurrence. So in early recurrences, you need to do an extended scan like a PET scan, and that will be helpful. So there have been numerous papers on GCT, and if you go through even in the best of hands with the experienced management, with the best of adjuvant therapy, with the best amount of disease clearance, you have a 7% chance of recurrence. Various papers quote between 7% and 44%. So you have to be ideal that there is a chance. You have to be knowledgeable of the fact and also inform patients that you have a chance of recurrence. Numerous factors have been discussed for recurrence, and nowadays even the use of denosumab has been shown to have a higher recurrence. The initial presentation, intra-articular contamination, pathological fracture. But the one important factor which affects is the adequacy of disease clearance. So you need to make sure, you need to use even dental mirrors to see all areas, all cortices are completely taken, you have cleared the disease, and that is the one factor which affects recurrence. So the last thing, how long should a patient operated GCT be followed up? This is a very important, as we have seen in our previous case. If missed follow-ups, you can leave with metastasis. And especially in countries where there is not an established sarcoma service, it's very difficult. But you need to be aware that routine follow-up is a must, especially with the risk of recurrence and with the risk of metastasis. So ideally what is followed is a 3-month follow-up for the first 2 years, followed by a 6-month follow-up for the next 5 years. And then you need to follow up them annually till 10 years. So if you are going to operate on a patient of GCT, you have to be mindful of the fact that at least for 10 years, you need to be followed up, and then need to be in every X-ray, you need to take an X-ray of the local region, examine them, also take a chest X-ray for screening purpose, and only then can you say that they are disease-free. So you need to have a 10-year follow-up. So I would like to summarize my clinical considerations as GCT is a benign but an aggressive lesion, and clinicians need to be mindful that type 3 lesions in the Campanacci, where there is a soft tissue break and there is a soft tissue extension, and with cellular atypia seen on the histological slides, these are important factors with regards to recurrence. There is a higher chance of recurrence with these. Chest X-ray is enough for preoperative staging of the disease. You need to counsel patients regarding recurrence and also be mindful that metastasis is rare but associated with better outcomes, and surgery, biopsy is the choice for diagnosis, and intralesional extended curettage is the gold standard for surgery to attain good outcomes. Thank you.